Watermelon. Try one today.
Chic Leisure Limited, making life easier. Our renowned great tasting vermicelli comes pre-cut in regular and parch, packaged to make preparation simple. Attention all doubles vendors and roti makers, try our high quality pre-sifted bromate free all-purpose and whole wheat flour, low price and conveniently packaged. For wholesale and retail prices, contact Chic Leisure Limited, Warrenville, Conopia. Chic Leisure Limited, quality you can trust.
Never too early, never too late to recharge and hydrate. Get your daily dose the right way. Grab our oasis, now why wait? Never too early, never too late to recharge and hydrate. Get your daily dose the right way. Grab our oasis, now why wait? The greatest, the safest oasis for sure. Oasis, it's purer than pure.
Assalamu alaikum and welcome to Doctor in the House. It is my pleasure tonight to welcome all our viewers and listeners to another episode of Doctor in the House, where we continue to educate, raise awareness and increase knowledge for all medical aspects of healthcare. And it is hoped that this knowledge will allow you to make better informed health decisions and seek more appropriate health care. I am Dr. Amina Khan, specialist obstetrician and gynecologist, and I've been practicing in this field for over 20 years. I am very passionate about women's health. With me tonight is my very special esteemed guest, Dr. Laura Amiral, and she is a consultant dermatologist who obtained her MBBS degree through the University of the West Indies in Jamaica, followed by her specialist qualifications from the Royal College of Physicians in the UK, King's College and Cardiff University. She currently practices both in the public hospitals and in private facilities. This evening, we are discussing a topic which has made landmark history in the care of women's health. It is the first time that a medical condition has been renamed, and this is none other than polyendocrine metabolic ovarian syndrome, previously known as PCOS or polycystic ovary syndrome. And tonight, our topic will be focused on beyond the ovaries, understanding PMOS and your skin. Welcome, Dr. Amiral. It is a pleasure to have you join us tonight. So tell me, who is a dermatologist?
Okay, so wa alaikum assalam. Thank you for having me here tonight, this evening. So a dermatologist is a medical doctor who has undergone specialization and treats disorders of our largest organ, which is the skin, as well as the hair and the nails. Sometimes referred to as a skin doctor, but erroneously so, because it's not just the skin, the hair, and the nails. And as we are on the topic of PMOS, we also treat the underlying causes of disorders of the skin, hair, and nails. So I'm very happy to be here, especially to talk about PMOS with you, because it is something that I am particularly passionate about, because I have been seeing in my entire career a number of young girls, teenagers, women at various stages of their lives with acne, with hair loss, with hair growth, or what we call hirsutism, which is growth on the face or in a male distribution on the chest and abdomen. And I'm happy that they changed the name and there's more awareness now and that we're having the conversations. So it's not just about the skin, it's not just about the ovaries, it's a complex disease that encompasses the endocrine system, the heart, the metabolism, the skin, the reproductive system. So,
Well, you have summarized it very well, I must say.
thank you.
So, exactly. So, what is PCOS or PMOS, right? So, basically, the C has been replaced by M, right? But it is the same condition, it has just been renamed. And as we know it before, it is the most common endocrine and metabolic disorder or hormonal disorder that affects 1 in 8 women worldwide, or over 170 million women in their reproductive age.
That's interesting and very relevant.
Of course.
Why are some experts proposing the term PMOS to replace PCOS?
Right. So this new name was decided or arrived on May the 12th this year, 2026, and it was actually published in the International Medical Journal, The Lancet. And this was after 14 years of an unprecedented global process and project that was initiated by the Monash University in Australia in collaboration with over 56 professional bodies, organizations, and patient advocacy groups as well. So in collaboration, this unprecedented event occurred. PMOS, or previously known as PCOS, was discovered in 1935 by two gynecologists, Stein and Leventhal, who discovered during surgery multiple tiny follicles or fluid-filled sacs in the ovary, and the name was coined. However, decades later, research showed that, as you mentioned, the condition encompasses more than just the ovaries alone, and it's a whole body complex disorder. So it was felt that the name itself was misleading, scientifically inaccurate, and it led to fragmented care, delay in diagnosis, and incomplete treatment of the patient as a whole. So by renaming it, it was found that it would hopefully assist in correcting all of these, like misleading concepts and allowing patients to seek better care.
So can you briefly explain the terminology then?
Oh my gosh, so, right, so if we were to break it down, so it's polyendocrine, P, metabolic, P, M, O, ovarian, and a syndrome, right? So polyendocrine means that it is a hormonal disorder that involves many different organs. And although the exact etiology is unknown, it is felt that the driving force is insulin resistance. So again, we'll go into a little bit more detail of what insulin resistance means and what it causes. But basically, because of that, it causes an increased levels of the male hormones known as testosterone, and that drives all the other clinical manifestations. Metabolic, as the name now means, it is basically the emphasis is on the metabolic aspect of it. That means it's a complex symptoms or basically a number of symptoms that present together. And basically they include insulin resistance, high blood pressure, abnormal sugars, abnormal cholesterol, increased weight gain, especially in the central area of the body. And this together, the collection of symptoms is known as a syndrome, and again, it predisposes to long-term health conditions. And then thirdly, ovarian. Why ovarian? The name has been retained because the ovaries and infertility is still a major part of the disorder. And therefore, with irregular periods and lack of ovulation, it can contribute to infertility. So that, I mean, at the end of the day, it is a condition that is not inherited, but there's a genetic component to the condition itself. Can we put up the first slide, please? So this infographic basically is summarizing what we have just discussed in a nutshell. So PCOS, now renamed PMOS, basically causes all the different factors that are highlighted there. The major one being insulin resistance. And insulin resistance also contributes to high testosterone levels, and as a result of which it causes the irregular periods or the missed periods. It can cause excessive hair loss, acne, trouble conceiving, excessive body hair, and obesity or higher weight in the majority of women, or even difficulty losing weight. And you know, everything overlaps. But the important thing to mention is that not every patient presents with the exact same symptoms. So second slide, please. So this infographic is also very important. I know it's a bit wordy, but it really demonstrates the complex interaction of the condition itself. So in the yellow box, highlighting signs and symptoms, and as you see, it overlaps with the chronic health conditions, which we will discuss again in detail. Basically, the cardiovascular disease, mental health disorders, diabetes, hypertension, abnormal cholesterol. And for those women, there are many women who do get pregnant, who have PMOS. And that's also a misnomer. A lot of patients think that if they have been diagnosed that they cannot get pregnant, but as you would have seen and I would have seen in my practice, many women actually do conceive, right? So that's really important. But even in pregnancy, they are considered high risk. So unfortunately, there are risks for miscarriage, risks of hypertension in pregnancy, diabetes in pregnancy, and premature deliveries. So we have to also manage these patients during pregnancy as a high risk for better care.
Good. So you did touch on inheritance. A lot of people do ask, because they say their mom had it or their sister has it, they do ask if it's inherited.
Right. And yes, so we do not know the exact inheritance. So there's no gene that has been identified and say, yes, this specific gene as yet. But with further research, obviously with advancement in medical care, we may eventually know. But there's definitely a genetic component. So compared to the general population, if your mom or your sister has it, you have a 20 to 40% higher risk of getting the condition.
That is significant.
It is. And similarly, it has also been found, and this is why the condition is not limited to women only, because brothers and fathers of patients who have the condition also are at an increased risk of the metabolic syndrome.
Oh.
So it's like a whole family issue as well.
Yes.
It is not only limited to one person.
Okay, that's interesting.
So,
oh, sorry.
Yes. So basically, I mean, I've been talking about the syndrome in a nutshell, but let me try to discuss with you as well now. So a major part of the disorder involves the dermatological conditions, right? So why the skin changes? How do excess androgens affect the skin?
Right. So thank you for your question. Androgens are hormones that all women produce, or all humans produce. Men produce more of it, but in PCOS or PMOS, woman with those condition or that condition produces more of it, and it sort of turns up the volume on certain things like oil production in the skin, leading to increased acne, especially acne of what we call a hormonal pattern of the jawline and the chin, and acne that flares with the menstrual cycle, with the period. You also get irregular periods, as Dr. Amina would have mentioned. The androgens also, it's a weird switch because it causes increased hair growth in some places, but reduced hair growth in some places. So the increased hair growth on the face, or in what we call a male pattern, face, the chest, the abdomen, we call that hirsutism. And you get these thick hairs, that's hirsutism, and then you have hair shedding or hair loss, particularly from the scalp, in the front and top of the scalp. That's what we call alopecia. And these are all because of the excess androgens. In addition to this, you have what we call acanthosis nigricans, which is a thick, velvety darkening of the skin around the neck and under the arms. Sometimes it can be in the groin between the legs or under the breast. A lot of people think this is, they call it dirty skin, and they keep scrubbing and trying to get rid of it, which leads to irritation, which leads to more pigmentation. But it is a sign of PMOS, and it is a big sign of insulin resistance, not just in women, but in men. A next sign is skin tags. Also because of the androgens and insulin resistance. So you get these little fleshy growths around the neck, under the arms, between the legs, usually in areas of friction.
Wow, okay. So in patients whom you have seen, how many of them present with, like, which one of the symptoms? Is it all that they present with, or can they present with some only? You know, and at what age you would see them?
So I have seen patients from like puberty until, I had a lady this week who was like 50, perimenopausal, and wondering if she has, because she heard about PMOS, right?
Wow.
So I've seen them all at various stages, and they, like, a lot of people think this is just cosmetic. Acne is cosmetic, hair loss is cosmetic, hair on the face or the chin or elsewhere is cosmetic. You just go and get laser hair removal. It's not cosmetic. It is important to find and make sure that you do not have an underlying cause, especially as a woman going into their 20s, into their 30s, 40s, still getting acne, having irregular periods, having trouble conceiving, and having hair loss. It's important to be investigated by your dermatologist, because they usually investigate and refer to the obstetrician and gynecologist as necessary. And you may need involvement of the endocrinologist as well. So we do need a multidisciplinary management as well as a dietitian, so that every facet can be tackled. The most common, to answer your question, the most common complaint that I would get, like people would actually come for, is acne. But then when you talk to them more, they do have the hair loss, but they didn't put it together. They do have the hair growth, but they just say, oh, well, my mom had that, or my sister had that, so I thought it was just genes, which just brings us back into the whole conversation about genes. You know, or the same thing with the hair loss. They say their mom, sister, aunt, even their father, because we do know now that, you know, the men are affected with the metabolic syndrome, or their aunts and uncles did have hair loss from a relatively young age. So they just think is totally genetic. But the most common symptom I see would be the acne.
The acne,
yeah.
Sure. And you have brought across a very important point. So hence the reason why with the name change, we keep emphasizing that the condition itself is not isolated, and you do not treat one aspect of the condition. So basically, depending on the symptoms that patients may present with, they may turn up, they may see their general practitioner first, they may come to you first, or they may present to the gynecologist first. And hence the importance of taking a full comprehensive history and asking all the detailed questions that you said, so that we don't treat the symptoms only, right?
Yes.
We delve into the root cause of the problem, and basically if we don't do that, if we only treat the symptoms, you're not tackling the root cause, and therefore the condition itself will not be treated, right? The patients will just keep returning with the same symptoms over and over, because you said if they're just treating it cosmetically.
Correct.
Right, so you did emphasize the importance of a multidisciplinary care approach. So if they present to one particular specialty, we refer to the interspecialties so that the patients can be treated, as a whole.
Yes.
And that's why, for example, when you take a history, it's a full history we take. So menstrual history is also extremely important.
Yes.
And in particular, a lot of women will present with irregular periods. Now, when a young woman achieves puberty and she sees her first period, after the first year, to experience irregular periods is actually normal.
Yes.
So that's what we need to also let, so that a lot of parents, obviously moms especially, will come and they'll panic because they don't know if that's normal. So after the first year, it is normal. Within the first 3 years, you can have a certain irregularity as well too.
Yes.
But if it's less than 21 days, or if it's coming more than 35 days apart, after 3 years of seeing periods, that's not normal. And also, any period that there's an interval of 90 days or 3 months and a period isn't seen, that's also considered irregular as well. And it's important to see periods at least 8 times annually. So it's important for us to know that, because some patients may not know that if they're missing periods, whether it's abnormal or not. And then similarly, some patients may come with bleeding too frequently. So the opposite can happen as well too. So we see a wide range of the irregularity in periods. And another important factor is the weight changes. So, it is a sensitive issue because especially for teenagers and the body image, they can have a negative body image because of the difficulty in losing weight or maintaining weight. And also, as a result of that, they can have psychological impacts. So meaning suffer from anxiety or depression. So, we have to be very compassionate when we're speaking to these patients, and being able to advise them accordingly.
Agreed. And it's a lot. There's a lot of, especially with the acne patients and the hair loss, at the whole, all the symptoms of PMOS, there's a higher rate of anxiety, of depression, of insomnia, of a lower self-esteem. Some of my patients wear face masks to cover their face all day, every day, which sort of makes it a bit worse. They have some social anxiety. They don't want to go out. There's bullying, especially for the teenagers in school. There's harassment. And this can cause a significant psychosocial impact, to the point sometimes I do refer to psychiatry, to the psychologist because of that, so that they can learn to cope at the same time while managing their symptoms. A next big factor too is I do see a lot of women trying to conceive, and they have not really seen an obstetrician. They're just trying to conceive, and they just come to me for their acne. And I'm like, so do you have regular periods? No. Did you ever have an ultrasound? Yeah, but the doctor said there was no cyst. So I don't have polycystic ovaries. And I think that's a big myth that I'd like you to dispel today.
Right.
That once there's no cysts on the ovaries, it means they don't have polycystic ovaries. Because they say that.
Yes. So again, that is where as you said, it is a myth. And to diagnose a condition, we actually use the international guidance, international guidelines, which was produced in 2023, and we use the Rotterdam criteria. Now, it is important to note that a history of irregular periods and the classic sign of hirsutism or excess hair growth, 70% of women will present with those. We also do for an adult, we can do an ultrasound, pelvic ultrasound, to look at the ovaries. However, not every patient will have the polycystic ovaries, and it does not exclude, it doesn't mean that they don't have the condition, and vice versa. Some patients will have polycystic ovaries, but not have the syndrome, okay? And again, this is where the misnomer comes in. It is not pathological cysts, as the name would suggest, and that is why we moved away from the name. It is actually in the ovary or within the ovary, there are multiple tiny fluid-filled sacs, which are small, so less than 10 millimeters or 1 centimeter, and there's a classification and quantification. So per image, if one image is taken, it's more than 10, or for the entire ovary, it's more than 20 follicles, or the ovary itself is found to be enlarged in terms of the volume. So any one of the criteria can be used to diagnose polycystic ovarian ultrasound. So we say it's a polycystic ovarian morphology. That's how it appears. But to emphasize that this ovary does not need surgery. You do not need to remove the cysts. So it's not a pathological cyst. So it's different from how a cyst would truly be, right? So that's the difference. And even in adolescence though, so if you're a teenager up to the age of 20, it's not as sensitive to do the ultrasound, so it doesn't rule out the diagnosis. However, it is important if we're considering the condition to still do the ultrasound to exclude other causes. For example, a pathological cyst, one that is enlarged.
Yes.
You know, there are different types of cysts. For example, endometriosis could be causing painful periods or sometimes very heavy periods as well. So, you know, we still do the ultrasound to rule it out, but from the diagnostic point of view, as a teenager, if you have the classic signs and irregular periods, we can say that you're at a high risk of polyendocrine metabolic ovarian syndrome. Okay, and similarly, once you take the history, family history, you do their measurements. So basically, you do their parameters,
Yes.
right? We would have to do that in order to ascertain the risk for the metabolic syndrome. So we will now take a very short commercial break and return with our enlightening discussion.
Never too early, never too late to recharge and hydrate. Get your daily dose the right way. Grab an Oasis now, why wait? Never too early, never too late to recharge and hydrate. Get your daily dose the right way. Grab an Oasis now, why wait? The greatest, the safest, Oasis for sure. Oasis, it's purer than pure.
Construction Services and Supplies Limited has built a reputation over the years on reliability, honesty, and pride, with a qualified and experienced workforce to oversee all projects, commercial, industrial, and institutional. We deliver the highest quality designs, build and remodel equipped for the pulse of construction needs. Construction Services and Supplies Limited, 1324 Southern Main Road in Rapport, 648-8882. That number again, 648-8882. Construction Services and Supplies Limited. We are proud to partner with you.
Fruitopia, the drink that rocks your lunchtime. Fruitopia, Fruitopia, it's a drink that's hype. The citrus punch, fruit punch tastes nice. Guava, pineapple, that give me a vibe. We no want nothing less compared to the rest. Fruitopia the best. Punch any thirst when it comes to the test. Perfect thing for my lunch. Flavors pack a punch. Fruitopia, Fruitopia, it's a drink that's hype. The citrus punch, fruit punch tastes nice. Fruitopia, the drink that rocks your lunchtime.
Try our new passion fruit flavor today. Taste the passion.
Assalamu alaikum and welcome back to Doctor in the House with my guest Dr. Laura Amiral. We have been discussing polyendocrine metabolic ovarian syndrome, beyond the ovaries, and its relation to the skin.
Right, so we're discussing the diagnosis. How is PMOS diagnosed?
Yes, and so we have been discussing basically the fact that depends on where the patient presents. We need to take a full comprehensive history, a clinical examination, which includes taking the patient's blood pressure, taking the weight measurements, especially doing a waist circumference, since a lot of times the weight is actually accumulated in the central part of the body, and then a pelvic ultrasound if it is necessary. And most times we do need to conduct a pelvic ultrasound. And then some laboratory investigations as well, because there are other conditions that can present with irregular periods or excess testosterone levels, which can manifest clinically. So we do need to, there's a whole host of tests that we should do, including measuring the baseline testosterone levels, including a thyroid abnormality, because if patients have an underactive or overactive thyroid, they can have irregular periods, and that will not be related to polyendocrine metabolic ovarian syndrome. And we also do a prolactin level as well, because hyperprolactinemia, increased prolactin levels, can cause irregular periods, can affect fertility as well too. And then depending on the, it's also very important for all patients, regardless of their presentation and their weight, to do a cholesterol profile as well as a oral glucose tolerance test. So these two would help us to rule out the metabolic syndrome, meaning if they are at risk of it or if they do have it, meaning if they have abnormal cholesterol, very low HDL levels, very high LDL, which is a bad cholesterol, high triglycerides, and also if they have an abnormal fasting blood glucose or an abnormal 2-hour test. So those are two extremely important tests to be done. Can we put up the third slide, please? So this internal ultrasound scan, and as you could see on the left, there are about 1, 2, 3, 4 the tiny little fluid-filled sacs with one bigger one, which is known as a dominant follicle. So in a typical menstrual cycle, we will see that normally once a month, one follicle will develop, mature, and release an egg. And of course, should fertilization take place, the patient can conceive. However, the difference is on the right side, as we can notice, that is a polycystic ovary. So if we check, there are about more than 10 to 12 tiny fluid-filled sacs. And what happens in this case, because of the impact of the increased luteinizing LH hormone, it affects the production of the testosterone, which then prevents one of the follicles from maturing. So you have immature follicles and they all remain and one does not mature. And because of that, women can experience irregular cycles, and as a consequence of which also sometimes reduced or no ovulation. Okay, so I think this is a very important diagram to demonstrate this. And again, it emphasizes the point that surgery is not required except for fertility issues. Patients, if medical management is not working to assist with fertility, in some cases, laparoscopic treatment is required. And that laparoscopic treatment is to do what we call ovarian drilling. But again, patients have to be assessed properly to determine who is a candidate to have that done, because we do not want to reduce the amount of follicles that remain to be able to generate follicles to conceive. You see, so it's a delicate balance, but definitely not the first line management to do the surgery. So let's focus a little bit now on management of women who are diagnosed with PCOS or PMOS, right? And the mainstay, as we just emphasized, is not just treating the symptoms, but treating the overall condition. And it's actually a kind of long-term process, right?
It is.
It's not like a day to, it's not like one day.
No, it's a marathon. I tell my patients that.
Right.
It's not a sprint.
Right. And as you
Especially
mentioned,
when it comes to acne.
and as you mentioned, marathon, it emphasizes the need for exercise, right?
Yes.
So like all chronic conditions, diet and exercise and weight management are the mainstay of treatment for this condition. And I know it's very difficult because it requires a lot of self-motivation, a lot of practice in itself, and being able to say that, look, this is something that is for my own benefit in the long term, you know, so that there's no specific diet, is there, for management?
I usually tell my patients to try to do a low glycemic index diet, where they cut out, you know, the sugars
Right.
and the simple carbs,
Right.
because that's known to drive inflammation, especially in the skin.
Right.
And
So for the acne.
yeah, and for acne, there is some evidence to support that dairy aggravates it. So I do tell them to avoid the dairy.
Okay.
And I know you mentioned it's the hard part. It is the hard part, the lifestyle changes, which would be the diet, the exercise. But it's also the easier part because it doesn't involve the medications. So it's the hard part because you have to change your lifestyle. But it's the easier part because you don't have to do a skincare routine. You don't need to take tablets. You don't need to do blood tests.
Right.
Right?
Sure.
But people prefer the easier
Easier
route.
way.
I would like to mention, though, that a lot of people with polycystic ovaries are very ashamed because a fair bit of them are overweight. And we do know that the weight is partially due to the
Metabolic
aspect of it and not necessarily their lifestyle.
Sure.
Yeah?
Sure.
There is that which, you know, stigmatizes them, you know, with the obesity part or the increased weight. So I do advise on diet, exercise. A healthy sleep schedule is important because poor sleep can worsen insulin resistance, which you already do have, and you are already at an increased risk of becoming diabetic. So that's the
So it is
non-medical stuff.
Sure, but that's such an important fact, and it is a self-perpetuating cycle, unfortunately. So I mean, really, when I said a no specific diet, I was referring to, like, you know, they have the Mediterranean or
Yes,
the keto
yeah.
or the intermittent fasting. I mean, depending on each person's metabolism, I think, and this is where referral to the dietitian is extremely important because that's their focus, that's their specialty. They'll be able to sit and discuss with each patient their own, basically their lifestyle, their caloric intake, and be able to tailor a diet to their specific needs. But definitely a lower glycemic index diet is extremely important to manage the insulin resistance, right? And similarly, any activity is better than no activity, right? Better than a sedentary lifestyle. And that in itself, if you just lose like 10% of body weight, that improves and reverses the insulin resistance, right?
Yes.
And it can delay the onset of type 2 diabetes, cardiovascular disease, which can then lead to strokes as well, long term, and even obstructive sleep apnea. So this actually affects their respiratory system as well. So you see, we're talking about a whole body system here. It's such a complex disorder. So patients may even need to see the respiratory physician to manage their obstructive sleep apnea, which again could affect cardiovascular health, right? So that's so important also.
Yes.
And like you said, so the mainstay is diet, weight management, exercising, and then we move on to medical therapy. So there are also, because of the influence of social media, a lot of patients will go online and they will read a lot about different supplements and what they can take and what they cannot take, and a lot of these things are being pushed down, the throats of patients. But we have to be able to identify and let them know what is really important, what actually is beneficial and what isn't. So for sure, metformin is one of the mainstay of therapy because it's an insulin sensitizing agent, which unfortunately is associated with a lot of side effects though. And this is why a lot of patients may find that it's difficult to initiate therapy. But it's important for us to explain to them how to use it, and it's a gradual increase in the dose and not to start off with a high dose immediately. And that should hopefully improve, meaning reduce their side effects so they can be tolerant and use it long term. But that's one of the mainstays that has helped in terms of correcting the insulin resistance, helping with preventing developing gestational diabetes as well when they are pregnant. Similarly, for women who have very irregular periods, it is important to manage the number of cycles that you have per year. And one of the main reasons for this, which I didn't mention before, is the risk for what we call endometrial hyperplasia or thickening of the lining of the womb. Now, if patients do not have a regular cycle, this can lead to buildup of the lining, and which in the long term could lead to endometrial cancer. So the use of the combined oral contraceptive pill, and again, we have to recognize which patients are candidates for that because of the risk of getting blood clots or venous thromboembolism. So we need to assess the patients on an individual basis and prescribe it. And the low dose are the ones that we use. And then the additional benefit of the pill is the anti-androgenic benefit, right? So it helps with women control their acne, control the hair growth as well, but again, a minimum of 6 months duration of therapy. But if the combined pill itself doesn't work, is there anything else that we can prescribe in terms of helping with the acne and the hirsutism?
Okay. So, yes. But before we get to there, as you had mentioned, supplements, I remember I mentioned there, patients come and they say they had the ultrasound, they don't have polycystic or PMOS.
Right.
I have the other set of patients who Dr. Google and Dr. TikTok has diagnosed with PMOS, and they're taking berberine and inositol and zinc and magnesium glycinate and all sorts of things, Vitex.
Right.
Any, would you like to comment
any
on any of
benefit of
those? Any
those?
benefit?
There are.
And they are undiagnosed. They were diagnosed by Dr. Google and Dr. TikTok.
Sure. So that's the first thing.
Yeah.
Of course, before you even initiate any supplements, you must be properly diagnosed by a physician, right? And even when you do that, there are certain supplements that have been shown to have no negative benefits. So it may help, even if it's a placebo effect, but it may help. So certainly even inositol. Inositol has been shown to help with regulating cycles and possibly improving ovulation, but it's not proven. And then there's no set standard dose as to, okay, what is the maximum or minimum dose to use. But if they are using the inositol in particular, so the balance of the myo-inositol and chiro-inositol in a ratio of 40:1, and the dose that is recommended is 2 to 4 grams daily. Another supplement that has proven to be of benefit is the NAC, N-acetylcysteine. So those are the two that we can definitely recommend, in addition to the metformin. But the others like the berberine, the Vitex, and so on, those are not necessarily proven to work. And remember, these again are supplements. So they're not FDA approved. There's no specific dose that we can say, yes, this dose will work for this patient. But for sure, there are no negative benefits for some of those, so we can recommend them in addition to the traditional form of therapy.
Correct. There's a next one, spearmint tea. So there was a small study that showed some benefit for acne, especially hormonal acne. But you have to have several cups a day to really have that benefit. So, So in terms of the medical management, it depends on the patient. And as you mentioned, with their, their gynecologic history, right? So their age, their bloods, the results of their bloods, if it's a teenager versus if it's someone who is trying to conceive, because some of the oral medications that we use to treat acne and even some of the topical ones are contraindicated or cannot be used in pregnancy because it will harm the baby, right? So we usually start with topicals, the appropriate cleansers, and topicals, depending on the severity of the acne. But if it is more moderate to severe, it really depends on whether the patient is trying to conceive or not. So spironolactone is an excellent anti-androgen medication that is widely used for hypertension because it's a diuretic, so it makes you pass urine. But it works well in that it helps with all three manifestations of the PMOS. So it helps with the acne, it helps with the hair loss from the scalp, and it helps with the excessive hair growth, the hirsutism. And it doesn't need that much monitoring. But of course, if you're trying to conceive, it cannot be used in pregnancy, right? It can be used after pregnancy. It is safe in breastfeeding. Our next excellent medication is isotretinoin, right? But when you have that hormonal driving, those hormones driving the acne, it does help, but then you can have recurrence if you do not treat the underlying cause, like the PMOS, right?
So again, you treat the underlying
Yes.
cause simultaneously
Yes.
with the medical management
Yes,
for the acne.
correct. And that's absolutely not to be used in pregnancy. And you're not allowed to get pregnant while you're on it and for at least one cycle after, right?
Sure.
So a lot of our medications, even the topical retinoids, I see a lot of patients on topical retinoids like Retin-A and Adapalene, Differin, Deriva. They are not safe in pregnancy. And these things should be prescription, but they are not prescription here. And people don't know that it's not safe in pregnancy. So that's something to bear in mind.
So hence the reason again for as much as possible not having unplanned pregnancies. However, this is quite difficult though, because especially women who have irregular periods and they keep missing their periods, they assume that it's because of the PMOS. And I have had few unintended pregnancies that we see in the office because they can spontaneously ovulate and spontaneously conceive. So, that's why it's so important for patients to pay attention to their bodies, to their symptoms, and have adequate treatment. If they're using those medications, be on a form of contraceptive in the interim. So either use whether it's barrier methods or even the combined pill until they get their symptoms controlled to be able to conceive.
Yes.
Yeah.
So what I do from the first visit, I ask about their reproductive ambitions.
Of course.
Whether they are actively trying to conceive or even passively, like if it happens, it happens. And I let that guide my management. So in that way, I do not put them on something that would affect a pregnancy if they do conceive. So we have that discussion.
Great.
Yeah.
And that's really important. And what about, can patients benefit from things like chemical peels and laser treatment as well?
Certainly they can. It is helpful. They are helpful adjuncts
Right,
to
so the cosmetic
medical
part.
management, especially if we tend to have a lot of dark marks or post-inflammatory hyperpigmentation and scarring from the acne,
Right.
especially when it's the nodulocystic type acne. So the peels can help with the pigmentation, and it can also help with the acne, and while the lasers can also help with the scarring and the pigmentation. And to a certain extent, the lasers can help with acne.
Excellent. That's really good to know. One point to bring up here too, if patients are on the combined oral contraceptive pill, it is important for them to know that that medication needs to be discontinued for at least 3 months prior to doing any hormonal blood tests, because it can affect the results. So we will not be able to get accurate results. So again, that medication has to be discontinued prior to doing those blood tests. I want to quickly discuss some myths and facts, so we could try to dispel some of those, right? So one of them is PMOS only affects overweight women. And we already have said that no, that is not the case, because women who are slim can also develop PMOS, right?
The next one is acne is just cosmetic, as I would have previously mentioned. It's not just cosmetic, it reflects hormonal activity and may require medical treatment.
Right, sure. So I think I already addressed this one. Women with PMOS cannot become pregnant. Of course, this is definitely not the case. I have had a few women in my practice who have had PMOS and they already have 3 and 4 kids. And a lot of them were spontaneously conceived, or some of them with assisted fertility treatments, such as ovulation induction medication, or even as far as fertility. But yes, many can conceive naturally without treatment.
Next one, hair loss is permanent. It is not, but it can progress to the point where if you leave it long enough, you can lose the follicle and there will be no follicle to stimulate. So from the time, if that is your main symptom, hair loss, you should seek medical attention from a dermatologist as soon as possible to be investigated and treated. It's better when the follicles are stimulated as soon as possible rather than leaving it and just saying, oh, well.
Okay, sure. PMOS is only a reproductive disorder. We have already addressed that. It definitely isn't. It affects metabolism, cardiovascular health, mental health, and the skin. It's a complex overall body syndrome. So some other questions that we would like to address. Can teenagers develop PMOS? So the answer is yes, definitely. Adolescents can, and that is why it's important to address the symptoms of concern and manage accordingly. Is PCOS curable? So unfortunately, at this point, it isn't. It is really a lifelong disorder, even postmenopausally, and it is something that needs to be managed long term. Does sugar cause PCOS? PMOS? No, sugar itself doesn't. But of course, because of the genetic component, it can have an impact. Can acne return after treatment?
It can, yes. Especially once the underlying etiology is not managed,
Right, so that's why
the hormonal aspect.
So it has to be managed in tandem, together.
People often think with the facial hair, if you shave it or you remove it, it will grow back thicker. That's not true. Shaving, even the hair on the body, does not cause it to grow back thicker. It doesn't change the number of hair follicles or the width of the hair follicle. So that's a misnomer.
Okay, sure. So is laser hair removal safe?
Absolutely, 100%.
Okay, great. And we've already addressed the long-term health risks. Again, just to emphasize that because it's a chronic metabolic disorder, the risks for patients are long-term. So it's very important for us to know that we manage, and the earlier we diagnose, then the more appropriate care we can tailor for the patients, so we could maximize their fertility benefit, we could maximize their body image, manage weight, and delay and hopefully prevent the onset of cardiovascular disease, diabetes, etc. Yeah? So PMOS, in summary, is a lifelong endocrine or hormonal and a metabolic condition. But early diagnosis and appropriate treatment can definitely greatly improve health and quality of life. Would you like to make any closing comments?
Just one of the things I'd like viewers to remember is that persistent acne, unwanted facial hair, thinning of the hair on the scalp, or darkening of the skin, as we mentioned around the neck, under the arms, are not just cosmetic. Your skin speaks to you. Most people don't listen, but your skin speaks to you. So listen and see your dermatologist as soon as possible if you have any one of those.
Great. That's very, very true. So in summary, again, PMOS is much more than just the ovaries. Recognizing the hormonal, metabolic, dermatological, psychological aspects empowers people to seek timely care and to improve long-term health. So I would sincerely like to thank you so much for giving of your time and coming here with us. It was really a lovely discussion, I think, and I'm really hoping that this knowledge would empower our patients to seek better care, appropriate care, early care, and just feel good about themselves, because with advancement in medical care now, that's the importance. Patients can avail themselves of a lot of the medical management that is available, and they could benefit from it. So I'd like to thank the IBN crew, the staff, and all the viewers and listeners for making our programs so invaluable. And please join us again, inshallah, for more enlightening episodes. Thank you. Assalamu alaikum.
For the everyday lowest prices on all grocery items, trust Low Cost Supermarket for the widest variety of quality products at low prices. Freshly picked fruits and vegetables, healthy products for your well-being, high quality meat cuts, and a warm and friendly service. Low Cost Supermarket, Southern Main Road, Cunupia.